Thank you, Chairman. Good morning, ladies and gentlemen. I'm Chun from Ulsan Medical Center, Korea. Today's my talk is about how to preserve pulmonic valve in tetralogy of Fallot. It's an old topic. And frankly, I'm a little worried that you would think that I and Dr. Choi may be avatars of Dr. Yoon. Anyway, yes, I think you all know how to preserve the pulmonic valve annulus in tetralogy repair. So in this presentation, I'd like to introduce our institutional strategy for pulmonic valve annulus preservation in tetralogy repair, and my personal tiny little difference of pulmonary valve annulus preservation strategy from our institutional one, and my thought about recent over-enthusiasm on annulus preservation in our society. So first of all, we have to remind why we have to preserve the pulmonary valve annulus when tetralogy repair. As we all know, pulmonary insufficiency can lead to RV dilation and RV dysfunction, arrhythmia, and even sudden death. There is no doubt that pulmonary regurgitation should be avoided as possible as we can. Well, pulmonary valve annulus is leaflet hinge of the pulmonary valve. We should preserve it. Yes, Dr. Yoon. Well, our institutional strategy for pulmonary valve annulus preservation in tetralogy repair has mostly been established by Dr. Tae-jin Yoon. He is always trying to preserve the annulus and mostly has accomplished it for the patient in this gray zone. So for fair comparison of outcome in patient with annulus preservation and transannular repair, matched cohort was used, and finally it was found that annulus preservation is better for avoiding future pulmonary valve implantation. So this finding drove him further devote himself to aggressive annulus preservation. There are multiple components in pulmonary stenosis, supravalva, valva, and subvalva in tetralogy. But if supravalva stenosis could be completely relieved, optimal pulmonary valve annulus size itself is quite smaller than normal, smaller than expected. This table, you have already seen it. So this table shows the smallest acceptable annulus size for annulus preservation. So let me emphasize again, please bear in mind that the other component of PS, supra and subvalva, should be eliminated for applying this size criteria. In addition to the annulus size, valve morphology, type of VSD, and post-bypass pressure ratio should also be considered. Techniques of pulmonary valvuloplasty is well known, including commissurotomy, commissural mobilization, and leaflet slicing, and so forth. However, if annulus size is large enough for annulus preservation, then leaflet itself is left untouched for preventing future development of pulmonary insufficiency. At least, the commissure had better not to be violated for preventing future pulmonary insufficiency. Valvotomy itself can enhance the opening of the valve with maintaining valve competence. For the other component of pulmonary stenosis, MPA patching is used. An additional aggressive use of alveoli patching is a unique feature in our annulus preservation strategy. As you have seen in the previous video, infundibular patching could significantly reduce the need for transannular patching. And the next feature of our strategy may be somewhat controversial, but it is utilizing systemic depermanate shunt for annulus preservation. We have previously proved the growth of the pulmonary valve annulus after systemic depermanate shunt. And for successfully achieving annulus preservation repair after systemic depermanate shunt, initial valve annulus Z-score should be greater than -4. Yeah, this is the brief summary of our institutional strategy, and I'm an individual surgeon, so as an individual surgeon in our institution, I personally hold a significant, slightly different opinion in some aspect of our policy. Firstly, VSD was closed exclusively through tricuspid valve. It could minimize the need for or the size of the RV outflow tract incision if needed. And if RV outflow tract incision is needed, it is performed only after it is confirmed that the pulmonary valve annulus is large enough for annulus preservation. In addition, I'm cautious about the palliation just for growth of the pulmonary valve annulus for future annulus preservation repair. And the last theme, recently in Korea, enthusiasm for annulus preservation seems overheating, I feel. So I'm always curious if pressure loading is always better than volume loading, and residual stenosis is better for RV health than insufficiency, and repeated reintervention or reoperation is justified if pulmonary valve annulus could be preserved. I have yet to find the answer for these questions. And I'm also worried that young surgeons are always confused and likely to misunderstand the annulus preservation. And also, young generation could be discouraged if they cannot preserve the pulmonary valve annulus in the OR. So, transannular patch is a demon? It's a crime or criminal? What is that? So, let's take a look at the TOF repair in a different perspective. I'd like to show you our TAP outcome from 2001 till 2010, a total of 215 transannular patch repair for tetralogy were included. So 20-year survival rate was 96.5%. And most patients don't need cardiac medication and be in New York Heart Association Functional Class 1 at the latest follow-up. Although the freedom from PVR rate was 68% at 20 years. Is TAP still a demon? I'm not sure. In addition, residual stenosis might be beneficial for preventing RV dilation and preserving RV function. So I think TAP could evolve. So in some summary, We have to make every effort for annulus preservation, even with an aid of RVOT patching. I agree. And optimal pulmonary valve annulus size for annulus preservation is much smaller than normal, than we expected. And annulus preservation is acceptable when post-bypass RV-LV pressure ratio less than 0.7 to 0.8 or RV systolic pressure less than 60 millimeter of mercury. And if annulus preservation could not be achieved, transannular patch is a reasonable option. Thank you so much for your attention.